We'll frequently talk and discuss cases. So even if we don't want to send somebody from Fredericton, doesn't want to send someone down here, they have some, just want to bounce something off with somebody else, they'll give a call. And the same thing would happen if they wanted to talk to another pediatric cardiologist, for example. So the system works well, and I think it's very supportive of making sure that we have the care that we require for the moms and the babies. And Code Purple doesn't mean our doors are closed. Code Purple means that we're at capacity, and it means that we need to work even harder than we usually do with our partners. We had everybody moved that could possibly be moved, and we were still full. And in those kind of things, what it takes is then an arrangement that when we do get that call for, I have yet another preterm baby that needs to come, if we can't take care of the baby, where else in our region could that care be provided? And we have a nice working relationship in that case to know, can Moncton take that baby? Can Fredericton take the baby? Can St. John take the baby? And then if it's a mummy, where can that mummy go? Back to that, who is the sickest part of this dyad? Does the mummy need a maternal fetal person? Or does the mummy only need a regular obstetrician, but we need a neonatal bed? Or is this a mummy who's really healthy, but a baby who's got a surgical problem? That will depend on how we prioritize who's going to go where. It takes lots of communication, and it takes good working relationships. And again, sharing the services for saying what services and what babies must be here versus who could we share with other people, and how can we make sure that even when we're really busy, and it's not great to have to go from Yarmouth to Halifax, let alone having to go from Yarmouth out of the province, but where can my baby and my mommy get good care? And that's just an ongoing working relationship. It's a tribute to the people who work in all of the centers for how much time and effort they're willing to put into saying, okay, how are we going to continue to provide this service? This is not for neonatology and high-risk maternal care is not a new story in the country. It happens in every single intensive care unit across the country every day. And part of the reason for that is that our birth rate across the country has been going up. Okay, it's just it must be an echo boom of an echo boom. We saw dropping birth rates for quite some time, and now for the last couple of years they've started to inch back up. Part of it is that the kinds of mothers and babies we have are different now. Our moms tend to be delaying having their kids till a little bit older, and when you're a little bit older, things often are a little bit more complicated, both with mom's pre-existing health, with things like diabetes and hypertension, because pregnancy is not terribly easy on a body, but also more complicated infants, babies with complex congenital heart disease who are also happen to be 10 weeks early. That's a change in the kind of baby that we used to see over 10 years ago. Okay, greater numbers of late preterm infants. Now, late preterm infants, those are like 4 to 6 weeks early, so not terribly early, and not the ones that keep me up all night most of the time. But babies who don't tend to feed as well, who tend to get a little bit more jaundice and need to be in hospital a little bit longer, tend to have a little more problem with infection. That part of the population has gone up quite drastically. So although the birth rate's gone up, it's proportionally gone up in the preterm population, which is good for me because I'll always have a job, but a little bit difficult in the fact that it takes a little bit more to have those babies be healthy. It correlates with a little bit with advanced maternal age. It correlates probably with an increasing incidence of multiples, and the increasing incidence of multiples has to do with reproductive technologies in some part. Well, I'm talking about preterm babies as if they're garden everyday kind of things. We have about 150 babies less than 32 weeks in the province per year. Okay, and that's in a birth cohort of about 9,000. So you're really not talking about huge numbers. If we did not have a full service perinatal center, so perinatal center does all the high risk pregnancies and deliveries, and we did not exist as a pediatric subspecialty center, the care for patients that would be requiring those super specialized services would have to go out of the Maritimes. When we were on our Code Purple and we're really full, one of the big worries was what happens if we have a neonatal surgical patient. What will we do with them if we absolutely can't provide care? And the answer was we'll have to look to Montreal or Ottawa or Toronto. equally to what would happen if the IWK didn't exist, you'd have to ask a question about, well, how come we don't have more IWKs? And the answer is because we don't actually have enough patients to have more IWKs. And to be able, it's a very costly and expensive thing to have enough of all of the specialists and subspecialists to be able to provide the service, knowing that you can't only have one pediatric cardiologist or one pediatric endocrinologist or one MFM for a whole province, because there's too much work. And even if there's just enough work, that person can't work 24/7. What would the IWK do without New Brunswick for the surgical cases? That would be bad. Because it's not only keeping current, it's keeping good at what you do. Okay, and you have to do enough of what you do to stay good at it. So right now, if I looked and said, what is our catchment area, the right kind of catchment area, and the answer is yes.